Kitab Al-Fatihah. Good. All right. Let's begin with the presentation.
Hello, you can see the slide?
Yes.
Yes.
Okay, for PBS today, the PBS is PBS 5, and we were supervised by Dr. Syed. And the topic for us today, there are three topics, which is the pale child, the child with easy bruising, and easy bruising, and child with jaundice. So let's first start with the pale child, which is by me, Muhammad Arif. So let's talk about that. So mainly, in this presentation for the pale child, I will present to you guys regarding on how we want to approach this kind of problem. So for example, you can imagine like a 5 years old girl can we still complain due to failure for 1 week's duration. So how you want to approach this kind of problem? So of course, this is my outline, okay? And of course, for every case, in general, our general approach is that history taking, physical examination, investigation, and also lastly, management, right? So let's get started. So in history taking, we want to know whether the failure, the causes of failure, it is due to anemia or not, or if it does due to anemia, we want to know the causes of anemia. Let's talk about that. So this is the cause of failure in children. You need to know that failure is not only manifestation of anemia. There are a lot more other causes of failure, like decreased tendency of skin to pigment, alteration of the consistency of the subcutaneous tissue, like in edematous state and also hypothyroidism, decreased perfusion of the cutaneous mucosal vasculature, and also like in hypotension and vasoconstriction. So there are a lot of causes of failure in child, but you guys, if you want to know more, you read by yourself. But I will only focus on anemia in this scene. So for example, that patient just now present with the symptom of anemia like lethargy, pale, irritability, decreased exercise tolerance, poor oral intake. And in here, you also need to ask regarding the onset, severity, duration, and how they notice the symptom. And you need to recognize as well the severe or acute symptom of anemia like headache, vision, blurriness, palpitation, and dizziness or faint. For example, you get this child and they present with this symptom, and you look up all other causes of failure just now. So now you think that this is anemia. So you need to know the causes of anemia, which is quite a lot. So as you can see here from Sunflower Illustrated Textbook of Pediatrics, they divide the causes of anemia systemically, according to the pathophysiology, which is the impaired red cell production, increased red cell destruction or hemolysis, and blood loss. So as you can see here, a lot of it is actually a broad causes that can lead to anemia, but you can see the red colored box there. That is the one that I will touch a bit. So you can, as we know that causes of anemia is really broad, so we can specify the causes of anemia based on the patient character, the associated symptom of anemia, and also other history. Okay. So for example, in patient character, so the age of patient can give us the clue regarding what are the underlying causes that lead to anemia. For example, for if the child from birth to 3 months, they can be due to physiological anemia, pathological anemia due to this. And for 3 months to 6 months old, they can be suggestive of hemoglobinopathy like thalassemia. And in this range of age, usually where the patient will present with IDA or the iron deficiency anemia will cause anemia in this range of age. And in toddler, children, and adolescents, usually they are more likely to get the acquired cause of anemia like iron deficiency anemia or infectious cause of anemia. So that's about the age. So this patient 5 years old just now. So we might that might suggest us that this patient might have acquired causes of anemia like infection due to infection, malaria, or iron deficiency anemia. So next is sex of the patient. In boys, usually it is related with the X-linked disease like disease PD. So this is a girl just now come to us. So we suspect that less likely, but it can be. And the girls is usually related with immune hemolytic anemia due to the higher prevalence of autoimmune disease, and due to anemia in girls, child girl as well, due to excessive menses in postmenopausal girl. So just now, 5 years old girl, less likely due to postmenopausal. And okay, next is race and ethnicity also give us the clue regarding the causes of anemia, like in hemoglobin S and C in the black and Hispanic population, in thalassemia syndrome in Mediterranean, and also, of course, us, which is Southeast Asian, and this is PD deficiency due to this ethnicity and race. So just now, the clue that we got from the patient character just now is from the age due to acquired, girls due to immunology, and we estimate the patient is Asian due to this thalassemia. So that's we got the info from the patient character before we ask anything. So next is we want to specify more regarding the causes of anemia. We ask regarding the associated symptom. So we ask regarding the symptom of hemolysis, like change in the urine color, pleural icterus, or jaundice. And we ask as well regarding the bleeding symptom that might cause, and bleeding also can cause anemia. We ask regarding the bleeding. We ask the stool color, blood in stool, and history of bowel symptom. And we ask as well regarding the bleeding tendencies like epistaxis, mucosal bleed, so menstrual history in girls, and other sorts of bleeding. There are also a specific symptom that we can ask, like fever, that we want to suspect that this is infectious cause of anemia. This adenopathy as well in leukemia and abdominal enlargement due to complication of anemia like hepatosplenomegaly. That is in associated symptom. So for other history, the thing that we want to ask is any previous episode of anemia, systemic disorder, or chronic disease that might cause the anemia. So if presents any of these causes, we need to include the duration, etiology, and anything that has been done to manage that problem, and ask as well regarding the history of transfusion. And we need to for past drug and allergy history, we need to know regarding the oxidant drug in D6PD, like the antibacterial, sulfonamide, omicrofin, or other bacteria like chloramphenicol can be the oxidant drug in D6PD. We ask as well regarding the chemotherapeutic agents because this can suppress the bone marrow and supplement as well. And you need to know that prematurity also increase the risk of IDA. So in birth history, you ask regarding the gestational age of the patient when they were born. You ask the maternal anemia or iron deficiency, and ask regarding history of jaundice and anemia in the newborn. And other thing you need to ask in developmental history is that whether the child reached the age developmental milestone or not, and the growth parameter, because a child with failure to thrive are more likely to associate with the IDA. And family history, we want to know whether this child might have the risk to get hereditary cause of anemia, like thalassemia or D6PD. We ask that in the family history. And we ask regarding social history, like traveling history. We want to rule out the malaria causes and also tuberculosis causes anemia in the child. So this is an example of drug that we call D6PD oxidant. D6PD, that was the D6PD. So other history that we need to ask is regarding the nutritional history. This is important because as we know that nutritional insufficiency with IDA, usually iron deficiency anemia. This is the statement, as you can see, the infant, the small fish. Inadequate intake of iron is common in infant because the additional iron is required for the increase in the blood volume accompanying the growth. So you need to ask the nutritional history. This is illustrated testing, sunflower. The iron from the diet may come from the breast milk, low iron, but 50% are absorbed. And infant formula also can give the source of iron to the infant. So you need to be supplemented with adequate amount of iron. and cow meats also have a source of iron in the diet. Higher in iron than breast milk, but only 10% are absorbed. So the thing that you can ask here is that the type of formula milk that are consumed by the infant. So we want to avoid this low iron infant formula because they need a lot of iron for this. And feeding of unmodified non-formula cow's meat, goat's meat, and soy meat. Why unmodified? This also we want to avoid in the infant because unmodified cow's meat can lead to the cow's meat protein induced colitis. So they can lead to colitis in the child. This will exacerbate IDA in infant. So late weaning as well can cause insufficiency in iron-rich complementary food because in elderly child, the child need to have other source of dietary source of iron like in the high source of iron can be in red meat and that we can read that. And we can ask regarding the symptom of intolerance, some insufficient consumption of iron-rich food. We ask whether they picky eater or not, and then Tika stress desire to eat non-food item which present in IDA, and pagophagia. Pagophagia is actually a symptom, one of the symptom of iron deficiency anemia, which is they want to eat ice or ice drink. They want to eat something cool. That is the thing that we want to ask in the nutritional history. Okay, just now patient come with pallor. In taking, we ask whether the anemia or not. We rule out all the causes of pallor, and we specify the causes of anemia by patient character. So next is physical examination, of course. In physical examination, the thing that you need to do is that in general examination, we want to look for anemia sign. We want to know the severity of anemia, and we want to look for the clinical sign that might suggest to us the underlying causes of anemia in children, and also we want to know the complication of anemia. So let's talk about that. For example, in general examination, the anemia sign, you can see the pallor in the eye, and usually the sign will appear if the HB is less than 7 gram per deciliter, and other side of pallor that we can look for is at the palm and also nail bed. And the severity, we can assess the patient alertness, consciousness, and the vital signs where the patient might appear tachycardia and also tachypnea in severe anemia. And the complication of anemia, and in cardiovascular examination, the patient can have murmur and gallop rhythm in severe anemia, and patient may have complication of cardiac enlargement. And in abdominal examination, patient might have splenomegaly or hepatomegaly due to the extramedullary hemopoiesis, and growth retardation, where we need to assess due to the anemic state. So from the general examination, the other important thing that you need to know, we need to look for causes, right? There are clinical signs, specific clinical signs that might suggest to us the underlying causes. For example, in the skin, hyperpigmentation, you can see from this picture, might suggest Fanconi anemia. Petechiae and purpura might suggest jaundice. Carotenoemia, likely in iron deficiency in infant. Carotenoemia is the yellow discoloration. It's like jaundice, yellow discoloration of the skin, but carotenoemia is due to the beta carotene, increase in beta carotene in the blood. In compared to jaundice, is due to increase in bilirubin. The other thing we look for is the cavernous hemangioma. This can be due to microangiopathic hemolytic anemia, and look for also in lower extremities. You can be due to the other clues that we can look for is the faces, where we look for the syndromic features like the picture. The frontal bossing, we look for prominence of malar and maxillary bone. This might suggest to us that the patient might have thalassemia or severe IDA. Surprisingly also, I never thought that the eyes can have a lot of signs that might suggest the underlying causes of anemia. So you can observe that. So the thing that shocked me the most is that I never thought that the G6PD here can have one sign, which is the other sign you can read by your own. So the sign that we can look is glossitis in iron deficiency anemia, regular stomatitis in vitamin B12 deficiency anemia. So chest, we not talk in detail about that, but this is that up to date. And hence, usually we commonly heard about the spoon nails due to the iron deficiency anemia and spleen enlargement as well. We need to this is usually due to complication of this disease. So the other things you can imagine, for example, you do the examination, physical examination, you find that the patient have hepatosplenomegaly. So you need to have the idea of what are the causes of hepatitis. You can imagine that yourself in the future, as HO, and this patient has anemia and hepatosplenomegaly, and your supervisor asks you, so what are the possible causes? Patient, child with anemia and present with hepatosplenomegaly. So you need to know, remember this. Yes, the patient can be due to malignancy, this and this. Remember, this is from the protocol. So just now we talked about history taking and physical examination. So from both of this approach, which is history taking and physical examination, might specify us. So we might get the idea regarding what are the causes of the anemia to the child just now. So now we want to do investigation. Mainly in investigation, we want to confirm the causes that we suspect before, and we want to know the severity of anemia and complication of anemia. So a lot of investigation can be done to look confirm the causes of anemia, like this. Actually, this is example. So a lot more actually investigation about that. So for full blood count or FBC, this is actually one of the most important investigation in anemia. In this FBC actually give us a lot of clues regarding what are the underlying cause of anemia in child. So first we look at the hemoglobin that may indicate the severity, but you need to know that the anemia is defined as HB level is below than the normal range, and the normal range varies with the age. And this is taken the normal range of HB in child, different age, different HB, you need to remember this. And NCV also different between the age. So that's one of the things that we look for, hemoglobin. The other indicators, we look at CV, MCH, RDW, reticulocyte, other cell as well, like white cell and also platelet that might suggest to us any others. The reason why I highlight in red this MCV and MCH because this is important. So let's talk about that. Okay, as you can see here, this is actually an algorithm from up to date, and for me, this algorithm is very useful because as you can see, example, so from this algorithm, you assess whether the child is you assess whether the child is anemia or not. So from HB, okay, if the child is anemia, you look whether the other signs are affected or not, with the white blood cell and platelet are affected or not. If no, we use this algorithm. So you can look at the NCV. So if yes, there are other algorithm after this. So for example, if the patient has low MCV, this might be the possible cause. MCV, this might be the possible cause. High MCV, this might be the possible cause. If the other cell line are not are affected, like the white blood cell, so platelet are affected, we need to use the other algorithm. So if the child is anemia or not, yes, HB is low, and other cell line is affected, yes. So if what are other cell line? If all are affected, low, all is low, this is the possible cause. If only platelet low, this is the possible cause. If the platelet is high, this is the possible cause. If the white blood cell is high, these are the possible cause. So these are the general idea regarding if the anemia with abnormalities of other cell line. So I will not talk in detail about this, but I will focus on the isolated anemia, which is anemia that are not affected by and not affect the other cell line and the algorithm just now. So let's talk about that. For example, the patient come to you, check everything, no other cell line affected, and the patient present with low MCV from the full blood count. So these are the causes: iron deficiency, thalassemia, or anemia of chronic disease. So from this, you need to know how to differentiate between these causes based on the investigation result. So these are one of the way you can look at MCV, of course, thalassemia and IDA decrease, and red blood cell count in iron deficiency anemia, of course, decrease because iron is lacking in iron, right? So lacking the substrate to make more RBC. So in thalassemia, the RBC might be normal because the production of RBC is normal, but it is abnormal. Normal production, but abnormal structure, hemoglobin. The abnormality is in the hemoglobin. In iron study, we look at the total iron binding capacity. This is like the availability of the transferrin. So in iron deficiency, transferrin is the transporter for iron. So iron deficiency anemia reduce lack of iron. So can be more transferrin available in the blood. So in thalassemia, normal, and serum ferritin as well. We can look at that to differentiate. Where serum ferritin is the storage, iron storage. In iron deficiency anemia, decrease. In thalassemia, it can be normal or increase, especially increase in the thalassemia with blood transfusion. That is one of the way to differentiate between the causes of microcytic anemia. So what the next thing I want you to guys to focus is the green box here. This is important because it is related with this Menzer index. Where Menzer index is used, we want to differentiate between the iron deficiency anemia and also thalassemia. Like I said previously, in IDA the RBC count is reduced because the iron is low, so substrate is low to produce thalassemia. So this result in, if the value is more than 13, it might suggestive of IDA. On the other hand, if the value is less than 13, it might suggestive of thalassemia. So this is important. Remember this. So this peripheral blood smear, you can see in normal peripheral blood smear, you can see there is a central pallor and the color is healthier. In compared to hypochromic microcytic anemia, there are hypochromic, which is central increase in the central pallor, as you can see in all the cells, and microcytic. So microcytic a small cell. So usually it is, we compare the RBC in relative to the white blood cell. Usually the RBC more or less the same size with the white blood cell, but in microcytic the size might be almost half of the white blood cell. There are also anisocoikilocytosis in anemia, in the hypochromic microcytic anemia in IDA. Like as you can see, this arrow, this is pencil shaped RBC. So this is in thalassemia. In compared to IDA, both of these is hypochromic microcytic anemia. But in beta thalassemia, they have this character, target cell, which is abnormal shape due to the abnormal hemoglobin in thalassemia. And also they have this teardrop cell in thalassemia. Okay, just now we talk about low MCV. You check the FPC, low MCV. So you it's maybe can be due to IDA or thalassemia. You differentiate between those two. So on the other case, if the MCV is high, so this is the possible cause. But I will only focus on the vitamin B and folate deficiency anemia. So we touch a bit about that. So anemia can happen due to folate or vitamin B deficiency. So both of these are required for DNA synthesis in production of RBC. So the deficiency results in megaloblastic anemia due to the impact DNA replication. So the pathology is the impact nuclear development but abundance of cytoplasm. So there are nuclear and cytoplasmic asynchrony. That's why the size of RBC is bigger. And if you take the bone marrow aspiration, you can see that large marrow progenitus in anemia due to folate vitamin or vitamin B12. Usually the clinical feature between folate and vitamin B12 deficiency is the same, similar clinical feature in peripheral blood and also marrow morphology in folate and cobalamin. Cobalamin is B12. Except in B12 deficiency, there are neurogenic abnormalities. So in physical examination, you might find the neurogenic abnormalities. So lab finding for anemia due to this is, of course, microscopic, relatively low red sign, reticulocyte count, and uniquely for me, there are hypersegmentation of neutrophils, and we will talk about that after this, and also my thrombocytopenia, myeloblastic change in marrow. So about what I told you just now, the clinical finding, where in B12 deficiency, in severe B12 deficiency, there are neurological findings like loss of position of sense, aesthesia, psychomotor retardation, and also seizure. Usually, the symptom will resolve if we solve the deficiency, so it will not permanent. So this is the peripheral blood smear. You can see the macrocytic anemia. So you can see, usually like I said previously, we compare in relative to the white blood cell. So a lot of RBC is bigger than the white blood cell, and this is hypersegmented neutrophil. This is the hallmark of the folate and B12 deficiency in the peripheral smear, where you can see the hypersegmented. Usually, normal neutrophil contain the nucleus consists of about 3 to 5 lobule, neglected lobule. So in this abnormal neutrophil, a lot, which is not normal. So might suggest this is the hallmark of the folate and B12 deficiency. So just now we talked about the result. If the FBC result, we found out that the patient anemia have high MCV without possible cause, which is vitamin B12 and folate. So now if the patient have anemia and the MCV is normal, so in compared to low MCV and high MCV, we look at the reticulocyte count. So if the reticulocyte count is high, this is the possible cause. If the reticulocyte count is low or normal, this is the possible cause. On the other hand, if the reticulocyte count is high, this is the possible cause. I will only focus on the hemolytic anemia a bit, touch a bit. So hemolytic anemia usually will be divided into the inherited or acquired hemolytic anemia. So I will talk only this memory defect, which is hereditary spherocytosis and also G6PD. So for hereditary spherocytosis, most common the sentence is not complete. This is the most common hereditary hemolytic anemia in cell membrane defect, related with cell membrane defect. So from peripheral blood smear, we can find the spherocyte, can be microcytic or normocytic, the spherocyte, and have an abnormality osmotic fragility. So osmotic fragility, we'll talk about that after this. And in FBC, it is likely to be high RDW, normal to low MCV, usually high in MCV. So the pathology is due to the hereditary autosomal dominant inheritance, and the mutation happen in the various structure of the membrane protein. Usually in hereditary spherocytosis, the treatment is splenectomy, but there are actually a lot of things I need to consider before we do splenectomy. You can read that in the protocol. So this is diagnosis. Peripheral blood smear, spherocyte. As you can see from this picture, spherocyte is the one that do not have the central vellum. So actually, in normal person, we can found the spherocyte, but in low number. In hereditary spherocytosis, the spherocyte count, as you can see, a lot, is about half or more. So that's why this is suggestive of hereditary spherocytosis. No central vellum, a lot of spherocyte. And like I said, for osmotic fragility is one of the tests that we do in hereditary spherocytosis. This test is like a stress test for the RBC lah, because the spherocyte are characterized by membrane loss and easy damage. So in hereditary spherocytosis, there are increase in the osmotic. That's about hereditary spherocytosis. Next is D6PD deficiency. D6PD is actually the enzyme that used to catalyze the step in the pentose pathway. So this is X-linked, common in boy. So in normal peripheral smear, we can have this white cell, and in the smear with more specific stain, crystal violet stain, you can see the Haines body. The Haines body is actually the denatured hemoglobin due to the oxidative, because we know that this SPD we need to avoid certain oxidative stress. So the denatured HB appear as Haines body as you can see here. So these are the overview of the specific causes of anemia and also specific investigation. Thalassemia, hemoglobin electrophoresis, megaloblastic anemia, we look for this, hemolytic anemia, this, hereditary spherocytosis, this. So can read lah about this. So lastly, management. So for of course, if the patient present with severe anemia, for example, just now patient with pallor, and the patient also tachypneic or patient loss of consciousness, we need to do acute management with ABC, everybody circulation, and also monitor the blood pressure, monitor the vital sign and everything. For definitive management, based on the underlying causes, where for this is the overview that I take, summary that I take from the protocol. For iron deficiency anemia, after you diagnose, this is the physical management, nutritional counseling, oral iron medication, blood transfusion. For spherocytosis, folic acid supplement, splenectomy. For thalassemia, regular blood transfusion, iron chelation therapy, splenectomy if indicated, diet and supplement, bone marrow transplantation. So, so the common case, I think the common case is IDA and thalassemia, but I think I will not explain more about that because you guys are already familiar. But I provide here is the overview of the thing regarding that, where I summarize from Nelson up to date and pre-protocol up to date, Nelson and essential. You can look at this because if I explain this, it will be long. And thalassemia, you guys are already familiar. This is from the protocol, investigation that to be done, management, detail of the management. I think that's all about the problem-based learning for PHI. So if you get nothing from what I told you or discussed with you previously, at least you remember the diagnostic algorithm by up to date. So to date, so just now we talk about the diagnostic algorithm. Remember that. So that I think that is very useful for real practical approach in for you guys. So that's all. If you guys had anything to ask, you can ask.
Okay, I have one thing. I want. What is the? How do you differentiate between? Okay. What do you understand by RDW? And also Mensa index is almost the same thing, like it's assessing the same thing.
RDW is red cell distribution width. So actually, this is the value indicate the variation of size between the red blood cell. So if the RDW increase, it means that there are variation of RBC size. For example, in anisopoikilocytosis.
So there's more anisopoikilocytosis.
RDW.
Yes. So which one is high? Which one has more anisopoikilocytosis? IDA or thalassemia?
IDA.
Why?
I think because of the production of RBC is impaired due to the iron deficiency.
So basically, because basically
I'm not sure.
in thalassemia, you have all this anisopoikilocytosis as well. You have the hypochromic microcytic anemia. But the thing is, with thalassemia, the problem is with the beta chain, isn't it? With the component itself. But in iron deficiency anemia, your iron storage, your iron content in your body, it differs according to feeding time. It differs according to the current level of iron that you have at that particular time, which changes throughout the day, changes throughout weeks, throughout months, depends on your diet and so on and so forth. So when you have more iron, when you have less iron, it will be more hypochromic microcytic. So the size of the RBC will differ according to the your current level of iron. So that is why the difference between your RBC sizes are more massive as compared to the thalassemia. So that's why in IDA you will have very high RDW and very high Menzer index. So these two are measures of the different sizes, are measures of anisopoikilocytosis. So the higher Menzer index, the higher the RDW, it shows that there is more anisopoikilocytosis. Okay, all right, proceed next.
Okay, that's all from me. Any question? If no question, I think we can proceed with the next presenter, Badrul.
Okay, can you guys see the slide?
Yes.
Okay, Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. I bid to everyone. So my name is Muhammad Badrul Nizam. So I'll be presenting about the child with easy bruising. So next, first we need to know about the definition of bruises or ecchymosis. So it is a collection of blood beneath the skin resulting from the extravasation of blood from the surrounding vessel. So what it's meant by easy bruising? So easy bruising is a bruising without a history or trauma or after minor trauma that would not have caused bruising in the past or bruising that is out proportion with the history of trauma. And according to the International Society of Thrombosis and Hemostasis, so significant easy bruising is said to be 5 or more bruises that is greater than 1 centimeter in diameter. Okay, so let's revise a bit about the hemostasis. So hemostasis occurs when there is an injury at the blood vessel where it will cause the platelet to be activated by the chemical release at the injury site and by the contact with the collagen. So it will lead to the formation of the platelet plug, which is a primary hemostatic plug. So followed by the stabilization of this platelet plug by the fibrin through the coagulation pathway. So for the coagulation pathway, I think you guys are very familiar with this pathway. So we have intrinsic and extrinsic pathway, which is intrinsic pathway is triggered by the damage to the vessel wall. So it will cause the activation of the factor 12, factor 11, 9, and then factor 8, which is will cause activation of factor 10 and then cause conversion of prothrombin to thrombin, which leads to the conversion of fibrinogen and fibrin that will eventually stabilize the primary hemostatic plug. And extrinsic pathway, which is involved factor 3 and also factor 7. Okay, so basically there are any disturbance or deficiency in the hemostasis pathway, which is a primary hemostasis or secondary hemostasis. So it could lead to the abnormal bruising or easy bruising. So basically we take a look at the first one is the bleeding disorder or bruising that is associated with the coagulation factor and fibrinolytic pathway deficiency, which is it can be further classified according to the isolated deficiency of specific coagulation factors, such all of the 13 factors. But the most common is that the hemophilia A, which is a factor 8 deficiency, followed by the hemophilia B, which is a factor 9 deficiency. And it can also be disorder with multiple deficiency of coagulation factor, which is in the case of vitamin K deficiency, such as what we learned yesterday, DIC, liver disease, and so on. So the second classification for this easy bruising. So it could be because of the platelet disorder. So platelet disorder we can further classify based on the quantitative platelet disorder, which is thrombocytopenia, which we interested in this case of easy bruising, or qualitative platelet disorder, which because of the deficiency in the platelet adherent or platelet aggregation, such as in the von Willebrand disease, Burnett-Solier syndrome, Glasman thrombus syndrome, which is a rare disease. So for the quantitative platelet disorder or thrombocytopenia, so we can further classify according to the decreased production and increased destruction of the platelet. So decreased production of platelet, it can be congenital or acquired, where congenital usually is a part of the syndrome such as Fanconi anemia, thrombocytopenia absent radii, which is characterized by thrombocytopenia and absence of the radius in the bilateral hand. Um, Biscott-Aldrich syndrome, characterized by the thrombocytopenia, eczema, and immunodeficiency, and osteopetrosis. While acquired, it's mostly because of the infiltrative process in the bone marrow by the malignancy, such as pneumonia, or aplastic process, such as in the aplastic anemia. For the increased destruction, we can further classify based on the mechanism, whether it is immune-mediated or non-immune mediated. For immune-mediated thrombocytopenia, the most common one is the idiopathic or immune thrombocytopenic purpura, or it can be uh, secondary to other immunologic diseases such as SLE or drug-induced. For the non-immune mediated, so it can be due to the microangiopathic hemolytic anemia or sequestration process such as in hypersplenism or hemangioma. Okay, so for the complaint, example, a 4 years old child brought to the pediatrician by her mother with complaint of severe bruising on her leg. So how we would approach this case? First is by history taking. So regarding the bruising, we need to explore more. So what we need to ask is that the first one is the age, whether the bruising is a bruising started in early childhood or in the later age of life, where in early childhood is usually associated with a congenital problem, while later in life usually acquired problem. And then we need to ask about the onset of the bruising, in which whether the bruising occur immediately after the trauma or delayed. Usually, immediate bruising is associated with the platelet disorder, while delayed bruising is usually involved the coagulation pathway disorder. And then we need to explore more about the characteristic of the bruises, in which we need to know the location of the bruises to differentiate whether this bruises is actually a normal bruises or an easy bruising. So usually normal bruises, it will occur at the distal extremity, at the lower limb, usually attributed to the fall or bumping into the furniture, especially in the toddler, while easy bruises, it can occur at the multiple location. Um, and we need to ask about the frequency as well. And then further history of trauma is needed because easy bruising usually is associated with mild trauma or no trauma, while normal bruising, we expect it to occur with moderate to severe trauma. And then any associated with bleeding from other areas such as mucocutaneous bleeding from the gum, nose bleeding, any deep bleeding such as bleeding in the joint or bleeding in the muscle, which could indicate the coagulation, more towards coagulation pathway. in compared to the mucocutaneous bleeding, which is more indicating to platelet disorder. And then we need to ask about any other associations such as rash, symptom, fever, which could indicate the patient have a previous infection that caused thrombocytopenia or pain at bleeding site, such as in hematrosis, in hemophilia. And then we need to ask about the severity, whether the patient the bruising occurs spontaneously or the occur from just a small cut, and we need to ask further about previous bleeding history, such as bleeding that is associated with simple surgical procedures such as a dental, post circumcision, which could indicate it's actually a pathology either in the platelet or coagulation pathway. And in a woman, in a female child, we need to ask about the menstrual history. Such as any excessive heavy menstrual bleeding or bleeding in between the cycle of the menstruation. Okay, next we need to do the systemic review. The most important thing is the anemic symptom. We want to know because we want to exclude other causes such as maybe the easy bruising when it is associated with the anemia. Maybe it's the cause of the bone marrow causes that cause pancytopenia. And we need to ask about other relevant history as well, such as past medical history. Recent immunization, because some vaccine it can trigger thrombocytopenia, such as in the case of the ITP or infectious disease, to exclude secondary causes of the um, thrombocytopenia. And we need to acquire about drug history, whether the patient is on aspirin or anticoagulant, because this could interfere with the platelet function and also coagulation factor function. And diet history also, we need to ask whether what diets that the patient are taking, probably because of the to exclude the nutritional causes of the bruising, such as vitamin K or vitamin C deficiency. And the most important thing is that we need to ask about the family history of easy bruising or bleeding disorder among the family, such as hemophilia, von Willebrand disease, and also maternal comorbid, such as ITP, because the child could be presented with a neonatal thrombocytopenia, as we discussed yesterday. Okay, so for the physical examination, what we need to look at, um, we need to do the detailed mucocutaneous examination. Um, we need to know about the appearance and distribution of the bruises, like I said, to differentiate between the normal and easy bruises, whether it's actually at the common site or at the multiple area. And then we need to look for any other forms of bleeding, such as petechiae, purpura, bleeding into the joint, hematrosis, and other finding we need to search for is lymphadenopathy, usually to exclude other diseases such as infectious in etiology or malignancy. And we also need to check for hepatosplenomegaly to exclude the systemic causes of the thrombocytopenia, and also joint exam for range of motion and effusion if for hematrosis in the case of the hemophilia. Okay, so basically, this is just a picture. What is petechiae? Petechiae is a non-blanching rashes, which is a pinhead size, usually less 2 mm in size, while the purpura is a more um, larger rash, which is consists of the adjoining petechiae, and hematrosis, which we can see there is a swelling uh, in the joint, leading into a joint space that causes swelling. Okay, for the investigation, so any child that we suspect with a bleeding disorder, so we need to do the basic screening, which consists of full blood count, blood film, and coagulation profile. So full blood count, what information that we need? We need to know most importantly about the platelet count. So whether the platelet is reducing thrombocytopenia, or it can be normal in certain causes such as type 2 von Willebrand disease or platelet dysfunction where it can be normal. We need to also look at the peripheral blood film where it might show us abnormally shaped platelet or any presence of megakaryocyte as a compensatory mechanism by bone marrow. And then we need also a screen for coagulation profile where we need to do prothrombin time to assess the extrinsic pathway and APTT, activated partial thrombus plastin time to assess for intrinsic pathway. Okay. Next, for the specific examination, so it depends on the cause of the disease. So if the investigation show prolonged coagulation profile, we might need to proceed with factor 8 assay, which will be reduced in hemophilia, or factor 9, and maybe we need to do also the von Willebrand factor antigen. In the case of von Willebrand disease or von Willebrand factor ristocetin cofactor assay to assess what the function of the von Willebrand to cause platelet aggregation in the presence of ristocetin. Okay, so basically this is the example of the peripheral blood smear with a megakaryocyte. So you can see there. And this is the screening test for bleeding disorder that I just mentioned just now, and with a specific disorder. Okay, you can read this later. So a simple approach to investigation of easy bruising. So usually if bruising, mainly at the leg, there is no other cutaneous or mucosal hemorrhage and no family history, we just observe because it might be a normal bruise. But if there is an atypical pattern with petechiae, purpura, and associated with mucosal hemorrhage, so we need to do the coagulation screening that I mentioned earlier. Okay, so this is the abnormality in the clothing screening, which is with the specific etiology, such as the isolated prolongation of prothrombin time, which can be caused by vitamin K deficiency, liver failure, some drugs, and isolated prolongation of APTT in the von Willebrand disease, coagulation factors such as hemophilia, or combined abnormality, both prolonged in the case of liver failure, vitamin K deficiency, DIC, and etc. Okay, so let's move on to the common diseases, which I'll touch 3 diseases in this presentation. So the first one is the immune thrombocytopenic purpura. So what is the definition of immune thrombocytopenic purpura? So it is the disorder which is characterized by the isolated thrombocytopenia, which is less than 100, in the absence of underlying cause. Why it is called isolated? When we do the complete blood count, there is no other abnormality except for the thrombocytopenia. Okay, so it can be categorized according to the primary or secondary. Secondary usually due to the other autoimmune disease, or primary, which is idiopathic. So it can be further categorized into the newly diagnosed ITP, which is diagnosed within ITP within the 3 months of the diagnosis, persistent ITP, which is between 3 to 12 months from the initial diagnosis, or chronic, which the ITP lasts for more than 12 months. And usually this ITP is triggered by the viral infection such as EBV, influenza, and so on, or vaccination, as I mentioned earlier. So in ITP, this trigger actually will cause the body to produce auto-antibody against platelet that cause the antibody-coated platelet to be cleared from the circulation by the reticuloendothelial cell. Okay, so what are the clinical features and investigation? So there may be history of preceding illness such as viral infection or previous vaccination. And because of the immune thrombocytopenic purpura is a platelet disorder, so it usually manifests as a mucocutaneous bleeding. It can be either a dry purpura, which is present with petechiae, purpura, ecchymosis, or wet purpura, which is a mucus bleed, such as from the nose, gingival bleed, GIT, genitourinary tract, or vaginal bleed. And they can present with serious hemorrhage, such as intracranial hemorrhage, prolonged epistaxis more than 5 minutes, or severe gastrointestinal bleed. And with some of the patient, even though it's rare, even though less than 1% affected, they might present with intracranial hemorrhage, characterized by increased intracranial pressure symptoms such as headache, persistent vomiting, altered mental status, seizures, and so on. Okay, on the on the physical examination, there is no other pathology or significant finding except for the purpura or bruising itself. Okay, so for the investigation in the immune thrombocytopenic purpura, the full blood count will show isolated thrombocytopenia as the definition, less than hundreds. And then the blood film may show reduced number of platelet or presence of megakaryocyte. And usually the bone marrow is not necessary in the case of immune thrombocytopenic purpura. And this immune thrombocytopenic purpura is a diagnosis of exclusion. So we diagnose based on the presentation, the clinical history with the complete blood count, which show isolated thrombocytopenia that could not be explained by other disease. Okay. So this is just a grading severity according to the up to date. There is 1 until 4, and then what is the management of the ITP? So usually 80% of ITP will remit spontaneously within 6 months of the diagnosis. So usually it does not need treatment. It just requires a wageful waiting management. And in the ITP, we need to advise the patient to avoid any contact spot that could triggers the easy bleeding, and avoid the medication such as aspirin and NSAID. So what are the indication of the treatment in the patient with ITP? So according to the PITS protocol, so we give treatment for ITP if there is a life-threatening bleeding, such as intracranial hemorrhage, if the platelet count less than 20 with mucosal bleed, if the platelet less than 10 with any bleeding. So the treatment of choice is either we can give oral prednisolone or IVIG. But this treatment is just to increase the number of platelet acutely, and it usually does not affect the long-term management of the ITP. So the mechanism is said to be that it reduces the clearance of the platelet by the reticuloendothelial cell, and it does not affect the antibody production. Okay, so this is the algorithm according to the up to date. So we classify the severity of bleeding into severe or non-severe, and then we assess the risk factor of severe bleeding in the case of the grade 1 to grade 3 bleeding, and then we decide whether to give the treatment or not. So if you are interested in this, you can view this later. Okay, the next common disease is hemophilia. So hemophilia is inherited.
I just want to remind something. I've had one patient before, came in with ITP. This I think is a 10 years old Malay boy. The issue is we did this patient came in with I think moderate ITP. The issue is we have advised the parents properly, but we didn't write letter to the school. So what happened? So well, we did right, but we only mentioned about not involving in body contact activity. So they tak involved in all the exercises apa semua. But it didn't clarify very clearly. So ada nurse dental datang sekolah and they did dental procedure at school. So bleeding tu, okay, satu bleeding tu very difficult to stop, tapi sebab dia minimal dental punya procedure, so bleeding tu dia tekan lama stop. Masalah dia akan jadi consumptive punya platelet use. So platelet dia memang dah already low. And then because of consumptive some more, what happened was it becomes severe thrombocytopenia, and then what happened? Bleeding in the brain. So the patient came in 2 days after the dental procedure with intracranial hemorrhage. Just want to highlight. So when we have a patient with ITP, we need to properly notify everyone that is involved with the patient. All right, proceed.
Okay, so the next cause is the next disease is hemophilia. So hemophilia is, we know, it is an inherited bleeding disorder which caused by the deficiency of factor 8 hemophilia A, factor 9 hemophilia B. Actually, there is a other type of hemophilia such as hemophilia C, but I will just include the hemophilia A and hemophilia B. So hemophilia is a X-linked recessive inheritance. So when it is X-linked recessive inheritance, so it's just affect the male gender, the boys. Okay, and some of the patient, there is the hemophilia occur because of the spontaneous mutation. Okay, so what are the clinical features of hemophilia? So hemophilia, they will be presented usually it can be as early as in the childhood, where presented with early bruising when crawling or walking, and because of its involve the coagulation pathway, usually it's presented with a deep bleeding rather than the superficial bleeding. Okay, so they will be presented with hematorosis in the large joints commonly, such as in the knee, in the elbows, which is swollen and painful. Muscle hematoma, bleeding in the muscle. They can also present with superficial bleed, such as epistaxis, gum bleed, and intracranial hemorrhage also. And there is history of excessive bleed after trauma or procedure such as dental or circumcision. Okay, for the investigation in hemophilia, so the FBC will show normal. There is no abnormality. But when we do the coagulation screen, so we find that the APTT will be prolonged. So because of its affect the factor 9 and also factor 8, which is involve the intrinsic pathway. So we know the APTT is to test for the intrinsic pathway. Okay, and for the specific investigation, we do the factor 8 or factor 9 assay, which show low factor 9 and also factor 8. Okay, so basically this severity of the bleeding in the hemophilia. So in the severe bleeding, usually there is less 1% of the clotting factor level. So they can manifest as a spontaneous bleeding in the joint, in the muscle. For the moderate severity, 1 to 5% of the clotting factor, they can have occasional spontaneous bleeding or prolonged bleeding with minor trauma. For the mild, more than 5%. So usually they will bleed with major trauma and the spontaneous bleeding is rare. Okay, so what are the management of hemophilia? So for the hemophilia, so we can give supportive treatment which consists of analgesia because of the pain, swelling joint, and then more towards prevention such as appropriate dental care, avoid contact spot, and avoid drugs that can such as aspirin, NSAID, anticoagulant, and avoid IM injection because they are prone to bleeding. And for the mild to moderate hemophilia, so we can give desmopressin, which is the analog for the vasopressin, which is ADH. So this desmopressin, it will induce the endothelial cell to secrete the factor 8 and factor 9. So basically it is can be used in the mild to moderate hemophilia but not in the severe one. And antifibrinolytic such as aminocaproic acid, so it can be useful in the case of the oral bleed. Okay, so for the hemophilia, usually we can give prophylactic treatment, prophylaxis in hemophilia in the case of, according to the CPG of hemophilia. So we can give prophylaxis after the first large joint bleed or after in the intracranial hemorrhage, severe intracranial bleed, or before the age of 3 years old, whichever comes first. So basically prophylactic treatment is used to prevent the further complication, which is a chronic arthropathy. So usually in the prophylactic treatment, we can give factor 8 or factor 9 replacement. During the bleeding attack, we can give the replacement therapy for the specific factor that is deficient. So according the up to from the up to date, so there is a different type of prophylaxis in the hemophilia A or B. So which is when episodic treatment is given at the time of bleeding. For the prophylaxis, there is a primary, secondary, tertiary, which in primary prophylaxis, we give usually before the age 3 years to avoid the chronic arthropathy. For the secondary prophylaxis, we give after there is evidence of 2 or more large joint bleeds, but before the onset of chronic arthropathy. The tertiary prophylaxis we give when there is already arthropathy, but to prevent the further damage. Or we can give also prophylaxis before the patient will go to surgery or procedure. Okay, so next disease, the last disease is a von Willebrand disease. So von Willebrand disease, it is an inherited disease which is in the autosomal dominant fashion. So it can affect both male and female. Okay, so it occurred due to the mutation in the von Willebrand factor gene, which result in either reduced or abnormal function of the von Willebrand factor. So what is the function of the von Willebrand factor? So von Willebrand factor is very important to carry the factor 8 in the plasma, okay, and mediate the platelet adhesion to the endothelium. So when there is a deficiency, so it can affect both, either the primary hemostasis and secondary hemostasis also. Okay, it is a common inherited bleeding disorder. Okay, so the classification, there is type 1, 2, 3. So type 1, where there is a quantitative deficiency of the von Willebrand factor, where the concentration is reduced. Type 2 is mainly dysfunction. The von Willebrand factor is there, but it's not functional. Okay, type 3, there is an absent or severely reduced von Willebrand factor. Okay, so for the clinical features, in von Willebrand disease, the severity of bleeding is variable, so it depending on the type of von Willebrand disease. So it can be presented with either bleeding from mucocutaneous bleeding, such as mouth or nosebleed, menorrhagia, excessive blood loss following trauma or surgery, or deep bleeding, because it affects both pathways, such as hematrosis or muscle bleed. Okay. For the investigation in the von Willebrand disease, the full blood count, complete blood count, can be either normal or can show thrombocytopenia. So, because it affects the platelet pathway, and for the APTT, it can be normal or prolonged because it depends on the degree of the deficiency of the von Willebrand factor. Okay, if it's severely reduced, such as in type 3, there might be prolonged APTT, while the PT is usually normal. Okay, and when we do the factor 8 AC, it's usually reduced because of the factor von Willebrand factor is important to protect the factor 8 in the plasma from being destroyed. So when there is absent, so there will be reducing in the factor 8. And also we can do the von Willebrand factor antigen, which will show reduce in the von Willebrand factor. And in the case of the type 2, where it's mainly because of the dysfunction of the platelet, so we can do the von Willebrand factor function assay, such as von Willebrand factor ristocytin cofactor assay, where we put the ristocytin in the plasma observation, where we actually quantify the platelet aggregation in the presence of the ristocytin, because ristocytin is actually antibiotic that could induce platelet aggregation. So in type 2 von Willebrand factor, usually the aggregation is reduced even with the inducer. Okay, so what are the treatment? For the prevention is the same as previously. We need to avoid the contact spot, avoid the drugs that could interfere with the platelet function, and said aspirin. And we can also give desmopressin, as I mentioned earlier. So desmopressin could induce the release of the factor 8, and also it's not just a factor 8, it also can induce the release of the von Willebrand factor also by the endothelial cell. Okay, and in the case of where we need rapid increment of the factor 8 von Willebrand factor, such as in the severe bleeding episode, so we need to give anti-hemophilic factor von Willebrand factor complex called human P, which is humate P, which is contained of both factor 8 and von Willebrand factor. So this is the only effective treatment in the type 3 where there is absent or severely reduced von Willebrand factor. And cryoprecipitate and fresh frozen plasma is not recommended because usually both of this is not virally attenuated, so it can cause the transmission of the virus such as hepatitis B. Okay, and for the oral bleed, we can use the aminocaproic acid as adjuvant treatment to stop the bleeding. Okay, so these are the differences between the hemophilia and von Willebrand factor in terms of the bleeding site, prothrombin time, APTT, and then the specific investigation. So you can view this later. Okay, so for the case that I give earlier, okay, this is a further history. So the mother could not recall any fall or bump that would cause the bruising. Further questioning, the patient had experienced flu-like symptoms several weeks earlier. There was no family history of bleeding disorder. On examination, the physician noted mucosal bleeding in the oral cavity, and also there are multiple areas of ecchymosis on both of her legs. Other examination are normal. So the investigation, the HB is 11, white blood cell 10, platelet 30, blood film show multiple megakaryocyte, and coagulation screen is normal. So anyone would like to try what is the diagnosis of this patient?
ITP.
Yes, correct. Because of only presence of the isolated thrombocytopenia in the investigation, as well as from the history and examination, there is no other history to suggest the secondary causes or other diseases that cause the thrombocytopenia. So that's all for me. This is my references. Any question?
Okay, that's quite extensive. Good. Next, how many topics we have? How many more? 2 more. 3
One
more.
more.
1 more.
One more, Doctor.
Okay, right. Okay, proceed.
Okay.
Baru boleh. Thank you. Okay. Bismillahirrahmanirrahim. Can you hear me?
Yes.
So my name is Muhammad Jami. So I will be the last presenter. We're going to present the case of children with jaundice. So okay, I want to go through first my slide. So first we're gonna go with definition of the jaundice, then we go with bilirubin metabolism, and then we go with history, in which I will highlight about how deep about the chief complaint, the condition or the red flag that we need to see, the causes of the jaundice, and also the complication. Then we'll go into investigation. Okay, investigation in which we need to really understand is it prehepatic, intrahepatic, or posthepatic. This may be helped by just doing fraction bilirubin and also liver function test. Okay, and then we manage the patient accordingly. So tu je lah presentation ni. Okay. So for bilirubin, for jaundice, the definition of jaundice is actually a yellowish discoloration that can be caused by deposition of bilirubin. So there are the two things lah. First, yellowish discoloration. Second, caused by deposition of bilirubin. Sebab there can also be other cause of changes in skin color or sclera or other tissue, but it's not really caused by bilirubin. So we don't consider it as jaundice. So I will tell you later lah. So in Nelson textbook, the bilirubin level is said to be increased if it is more than 85 micromole per liter in neonates, and also 34 to 51 micromole per liter in children. So this is bilirubin metabolism. So we can see. Can you see my cursor?
Yes.
Yes.
So we know that bilirubin is due to bilirubin actually from the blood RBC itself, in which there is biliverdin when the blood actually hemolyzed. So it will bind to albumin, then will transport it to they bind to albumin supaya dia boleh dissolve in blood. It can be transported through blood. So it will transport it into the hepatocyte lah. Then in hepatocyte it will be the albumin will the blood lah. Then the bilirubin, unconjugated bilirubin will be here. So the unconjugated bilirubin, they can is not hydrophilic. So the hepatocyte will conjugate the bilirubin and it will be excreted into biliary system, and it will enter the small intestine to join the fecal matter, the food particle. Okay. And also excesses of the bilirubin can result in clefts, in which the bilirubin can pass through the blood-brain barrier, and also it can cause increase in amount of bilirubin in the hepatocyte, can injure the hepatocyte. So as I mentioned, from the history, I divided into 4. If a patient come with you with jaundice, first we need to really identify the chief complaint. Is it really jaundice? Then afterward, we must assess the condition. So if the patient is not stable, we must stabilize first. You don't ask history first unless the patient is stabilized. So, and also if there are any red flag that we need to know, so if we can proceed with acute management first before we further action. Then if the patient is already stabilized, then we seek for the cause. This is where we take proper history taking and physical examination. So we are selling our provisional diagnosis and we are excluding our differentials. So then we need to see about the complication, because if we already have provisional diagnosis, then we have to know the complication of the disease, so we can identify the severity and also treat the complication. So we must scrutinize the chief complaint. So the chief complaint, if a patient comes with jaundice, we must really make sure it's really jaundice. So what I mean here, in other two cases that can mimic jaundice is carothemia and lycopenia. So carothemia is actually when the patient is eat a lot of carrot. So the carotene in the carrot cause a discoloration in the skin. And leukopenia is actually when the patient take a lot of red food such as beetroot, tomatoes, chilies. So it can also cause discoloration of the skin and become gray. So this is a picture of female with carothemia, and also there's a picture of a pumpkin. And then we go to the condition. We check for the condition of the patient. So if the patient vital sign is not stable, then we need to resuscitate the patient lah. And also we need to keep in good hydration status. So if the patient already stabilized, then we check for the red flags. So for red flags for jaundice, it's actually signs of serious liver injury lah, liver dysfunction. So it can be altered mental status due to connectors, coagulopathy, hypoglycemia to the liver, due to liver dysfunction, ascites due to also liver, gastrointestinal bleeding due to coagulopathy, and also if this sign is present, we should really be alert lah. If needed, then we can proceed with patient into intensive care. And these are the causes. So okay, to simplify the table, I tell you, so this is a pre-hepatic, intrahepatic, and post-hepatic. Tak buka kamera. Okay, for pre-hepatic, pre-hepatic is actually okay. For pre-hepatic, mana tu ni? For pre-hepatic is actually due to hemolytic lah, the hemolytic cause that increase the bilirubin in intravascular. So for intrahepatic is due to disruption of the hepatocytes. It can be due to infection, metabolic causes, toxic or drug, autoimmune such as autoimmune hepatitis, and also others. Saya Buchiari. Buchiari is actually thrombosis at the hepatic venous. Okay. And post-hepatic is the surgical jaundice lah. So this is mainly just due to structural abnormality yang actually disturb the flow of the bilirubin. Sorry. So then we really need to understand what is the disease that we are trying to put as provisional and also differential. So for identifying such thing, we have to go with history and physical examination. So this is the pre-hepatic. So as I mentioned, is hemolytic anemia, usually hemolysis. So generally for history, we ask about anemic symptom lah, due to hemolysis kan. So ask about anemic symptom, pallor, shortness of breath, reduced hypertolerance, and the patient only come with mild jaundice. We can see later in surgical or post-hepatic will be marked very severe jaundice. And abdominal pain is uncommon, and stool is yellow, and urine can be dark, can be light colored. So this is the left column is the special history if you're targeting certain disease. So we ask the patient about non-cures for GCHPD or any triggering factor. Then for familial disease, we ask about thalassemia, GCHPD deficiency, sickle cell disease, and also if there is history of consanguineous marriage. So we can also have about prolonged neonatal jaundice, and also ask about hemolytic uremic syndrome such as bruising, purpura, hematuria, and uremic symptom. And we can also ask about atypical pneumonia. So physical examination in general of prehepatic jaundice, there is splenomegaly with or without hepatomegaly. And patient may come with hemolytic facies, especially in thalassemia, and also there are present of positive family history. For investigation, I will go through this later lah. So for intrahepatic, there can be infection, metabolic, toxic, autoimmune, or others. So in general, anything that disturb the hepatocytes can cause jaundice. So the history that we ask is about jaundice, and also high color urine, because the jaundice actually escape from the hepatocyte into the blood, and also it went into the urine for excretion. And it can be pale stool because the jaundice don't really graduate to go into the small intestine. In fact, it backflow into the blood. So GI symptom may be present, anorexia, vomiting, and also abdominal pain. For special targeted history taking, we should ask about infection symptom if you are certain infection, family history of metabolic disorder, drug or nutritional history, in sometimes case of overdosage of paracetamol, because sometimes children see that the patient are taking paracetamol, so they think that is candy, but very bitter candy. And treatment for TB, rifampicin, if you remember, can cause orange secretion of the bodily fluid. So, and also prolonged TPN. Prolonged TPN can also cause liver injury and also jaundice. And for autoimmune hepatitis, we ask about autoimmune punya symptom lah, fever, and also arthritis, pruritus, hepatomegaly. For physical examination, for intrahepatic, because the problem is at the liver itself, patient can come with hepatomegaly with or without splenomegaly. But if the patient already have severe chronic liver disease, then there is no hepatomegaly, but the liver actually shrinking. But that is in adult lah usually. Okay. So post-hepatic jaundice. So post-hepatic jaundice is actually surgical jaundice. Is due to the structure of the biliary tree lah. So the history that we should get from the patient, usually the jaundice is deep jaundice or very severe jaundice lah, very marked jaundice. So because this block at the biliary tree, so the bilirubin cannot pass through. So the stool will be pale stool sebab tak ada stercobilin kat situ. And also what actually happen at the bilirubin yang stuck ni, it will patah balik, it will enter the blood circulation and it will excreted in the urine. So it will be dark colored urine lah, high colored urine. So and also since it entered the blood circulation, it can deposited under the skin and cause pruritus and xanthomas. And since we don't have bile because of the biliary tract, biliary tree obstruction, so vitamin A, D, E, K cannot be properly absorbed. So patient may come with symptom of vitamin A, D, E, K deficiency, such as coagulopathy due to vitamin K. So for specific history, we ask about constitutional symptom, because if we ask worry about tumor. And also in Alagille syndrome, patient may have dysmorphic features and also family history because it is dominant. So I will explain about it later. So I will go overview of certain diseases. So in children with jaundice, we must really exclude biliary atresia. So in biliary atresia, it's actually obstruction. Atresia is absent or obstruction of lumen. So biliary means the biliary tract lah, biliary tree. So what actually happened, the bile cannot pass. Because the obstruction, the bile cannot pass the biliary tree. So the stool will be pale. And also it increase the dark pressure, and this the bile that actually accumulated here can go back into the circulation, causing yellowish discoloration and pruritus. And also renal excretion after renal excretion can be result in dark urine. So for investigation, for blood, we check for liver injury. We do liver function test. Then we check for type of bilirubin that present. Is it really supposedly is conjugated lah. So and also we check for biliary tract injury. So this is usually by checking the alkaline phosphatase ALP. So ALP will severely increase in biliary tract injury, and also if it already affected the liver, it can cause coagulopathy. So then we can do, for gold standard, we can do liver biopsy and also hepatobiliary scintigraphy. So this is where we check the scintigraphy, like check for the activity of the liver and also biliary tract. So for management, we do Kasai procedure, and we give vitamin K supplement for the coagulopathy, and also even the patient already underwent Kasai procedure, they are likely that the patient will need a liver transplant years later. So
Typically, the surgical procedure used for biliary atresia is called the Kasai procedure.
this is
And basically what's done is the
roughly about the
damaged
Kasai
bile ducts
procedure.
outside the liver are first removed, and then the small intestine is cut, and one end is directly reattached to the liver, where bile comes out, also where the bile ducts used to be. This allows the bile to drain directly into the small intestine. The other end of the small intestine is reattached to another spot along the small intestine, such that now there's this path.
So now, after the Kasai procedure, there is a biliary excretion path and also path for the food. Okay. Food particle. I'm sorry. Okay. So before we go into others disease, it's really important what actually happened to bilirubin here. So bilirubin is being transported. This is the hepatocyte and this is the blood. So when there's unconjugated bilirubin here transported by albumin, so it will deliver into the hepatocyte. Now the bilirubin will enter the hepatocyte by a certain transporter lah. Then it will bind to urinyl diphosphate UDP UDP, and it will form conjugated bilirubin. It will bind to 2 UDP. So it will form conjugated, and then there will be another transporter that will excrete the conjugated bilirubin into the biliary tree. So if there is problem over here of the conjugation, there could be, it's called Crigler-Najjar syndrome or also Gilbert syndrome. If the patient is here, its transportation into the biliary tree, it also known as Dubin-Johnson syndrome. So for Crigler-Najjar syndrome, there are two types. First, type 1 and type 2. So both they are autosomal recessive. For type 1 is complete absent. Langsung tak ada UDP ni. So dia tak boleh nak conjugate. Bila tak boleh nak conjugate, dia tak boleh nak masuk dalam biliary tree lah. So dia akan patah balik. So so when we do blood test, is presented with unconjugated hyperbilirubinemia. So this unconjugated hyperbilirubinemia is high risk for connectors lah. So for diagnosis, we do DNA analysis and also liver biopsy. So for treatment, you can do phototherapy. However, we still need liver transplant. So for type 2, this partial absence of the UDP. So it can the patient come with also presented unconjugated lah still. But and there are risks of connectors. So treatment will give phenobarbital. For Dubin-Johnson, the problem is the patient so it's also autosomal recessive. There is mutation in ABCCA gene encoding for MRP, multi-drug resistant protein 2. So this protein is actually responsible to to secrete into the biliary tree. So what actually happened? Cannot be transported. So however, there are conjugated bilirubin. So the patient come with conjugated hyperbilirubinemia. And also, aside from jaundice, the patient can be asymptomatic but can be exacerbated by pregnancy or OCP, or if there are any other infection or illness. So for diagnosis, we give bromsulfalin. So when we give bromsulfalin, supposedly dia macam bilirubin, dia akan masuk into the into the blood, into the hepatocyte, then masuk dan masuk dalam bile duct. But if patient with Dubin-Johnson syndrome, when we give bromsulfalin, it cannot be transferred into the bile duct kan. So dia akan ditendang balik masuk dalam serum. So after we give bromsulfalin, we check for the serum blood bromsulfalin after 90 minutes. So we can, if the present, then it could be chance that patient have Dubin-Johnson syndrome. For Alagall syndrome, so this is most of them I mentioned about the disease is actually autosomal recessive, but this one is actually autosomal dominant. So family history could be very strong here lah. So mutation is actually at the chromosome 20p12. So patient will come with facial features of broad forehead, jendul, deep and distant eye, long and prominent nose, hidung mancung pun tak ada, bagus sangat kan. Betul, and underdeveloped mandible, ataupun some reference say dagu tajam, chin, sharp chin. So in the eye can be posterior embryotoxon. What is posterior embryotoxon is actually thickening of the cornea, tetapi it doesn't really affect the sight lah. So in shallow anterior chamber and microcornea. For CVS, patient can have pulmonary stenosis, pulmonary atresia, pathology of Fallot, VSD, ASD, coarctation of aorta, and also maybe can come with patent ductal atreosis. For musculoskeletal, now the patient will have butterfly vertebrae when we do CT scan, and we can see that few vertebra, maybe spina bifida, and also rib anomalies. And also the patient will have a bile duct paucity. So this is the causes of the jaundice. So this is the patient with Alagall syndrome. So the large forehead, distant eye, and also sharp chin. And from this image at left, we can see that this is the anterior posterior. So we can see that the shape of the anterior posterior lateral view, the shape of the spine is actually butterfly shape. Okay, enough with the disease. Then we go with the complication. So the complication, we really need to ask about the patient, the symptom. Actually, the complication of kernicterus, or known as bilirubin encephalopathy. So it's occur due to lipid soluble unconjugated bilirubin, the lipid soluble, the hydrophilic, lipid soluble, tapi the hydrophobic. Okay. So it can pass into the blood-brain barrier, and when pass the blood-brain barrier, they can duduk dekat brain tu lah. So dekat mana dia duduk tu can cause problem at that area. So it's occur when unconjugated bilirubin is more than 340 micromole per liter. So the risk factor, if the patient is worsened, if the patient comes with sepsis, asphyxia, GCSPD deficiency, autoimmune hemolytic disease, lethargy, acidosis, and when serum albumin is less, because serum albumin yang memegang unconjugated bilirubin dekat dalam blood. Okay. So it depends on albumin level, it depends on the blood-brain barrier permeability, level of unconjugated bilirubin, and also neuronal sensitivity to damage. So in kernicterus, it's not common in older child or in adult sebab they have the liver in elderly or old adult is capillary of conjugation process, and also the blood-brain barrier is more mature. So basically sebab liver dia more mature, blood-brain barrier more mature. Okay. Then we go with investigative approach. So as I mentioned, we need to identify is either prehepatic, intrahepatic, or posthepatic. So we can do that by checking the fraction bilirubin lah. So if it is unconjugated, it's usually may suggest prehepatic. But if it increase, it may suggest posthepatic. If AST and ALT is increased, it may suggest intrahepatic. However, it's a suggestion, it's not really a definite tak adalah macam mandatory is mesti intrahepatic, mesti post-hepatic. We must do further investigation. So for pre-hepatic, we check for reticulocyte sign just to divide either is hematological or non-hematological. So first we do with serum bilirubin lah. So we see if the patient has conjugated hyperbilirubinemia or unconjugated. If conjugated, it would be pre or post intra or post hepatic. If unconjugated, it could be pre-hepatic. So in unconjugated, we do reticulocyte count. So when the problem is hematological, the reticulocyte count will be increased. If non-hematological, then reticulocyte count will be normal. Why? Because when it's hematological, the body actually want to compensate. So the reticulocyte will be thrown from the bone marrow into the periphery. So next, if the patient is not non-hematological, so it's due to thyroid, maybe due to thyroid, or maybe breastfeeding, jaundice, physiological jaundice, and pyloric stenosis. Lepas tu, okay, and also if it's hematological, then we can do direct chromosome test, we can do a full blood count, full blood picture, HB electrophoresis, fluorescence test for GCPD, and osmotic fragility test. This is to check which one of the hematological problem is this. So if the patient is conjugated bilirubin, then we do liver function test. If there is marked AST and ALT, it may suggest intrahepatic. So we check for infection causes. We can do virus serology. For drug and toxin, we ask for the history. And also for autoimmune hepatitis, we can do anti-nuclear antibody and also liver biopsy. Or even for Wilson disease, we check for serum seroplasmin and urine copper. And also we do liver biopsy for Wilson disease. So for if the liver function test resulting marked increase in alkaline phosphatase, it may suggest in post-hepatic. By marked increase, I mean like 3 times more than normal value. So we proceed with imaging studies lah. So because it's surgical, so it's very structural lah. So we check for the structure of the biliary tree. You do ultrasound, retrograde, endoscopic retrograde cholangiopancreatography, magnetic resonance cholangiopancreatography, and if there is no abnormality or indefinite, we still must consider the intrahepatic cause. We check for others of the set. So for management, we treat the patient accordingly lah, according to the cause. So for example, okay. For example, if the patient come with in general, so if acute hemolytic crisis, then require hydration lah and close monitoring. And also immunosuppressive agent can be given into autoimmune hepatitis, penicillamine, and Wilson disease. Lepas tu kalau paracetamol poisoning, we give N-acetylcysteine. So we treat the causes according to we manage the patient according to the causes. So for example, acute hepatitis, we give fluid support and immunoprophylaxis. Okay, then we can correct other symptomatic management. So this is my references. Thank you. Any question?
One thing I need to remind all, because I've seen people miss this. Sometimes if you have jaundice, don't forget you need to look for all other problems with the liver. Because I've seen people focusing too much on the jaundice and they forget to look at other problems associated with liver impairment. So things like coagulopathy and so on and so forth. Because sometimes jaundice may be just the first signs of a huge of a more massive problem. So the patient may come in with jaundice, but if you don't treat it properly, if you don't look at it properly, and then you may miss major things such as coagulopathy and so on and so forth. Okay, all right. Any questions from anyone else?
Doctor, I have a question.
Ask the presenter.
Okay. Badrul, I would like to ask you regarding the bruises. How would you differentiate between a child abuse bruise and also a abnormal bruising and normal bruising?
For the usually the non-accidental injury bruises or result from any abuse. It's usually bruises occur at the atypical location lah. Actually, like bruises can occur at the back, around the groin area, and maybe the pattern of the bruises also can indicate that what objects that they use that cause the bruises. So there is a main difference lah between the normal bruises. Where normal bruises usually at the typical location, at the extremities, usually lower limb.
Yep, side shape and whether you can explain it or not. So usually side shape suspicious. So basically if the side is like mid thigh or areas that are covered, so these are usually more likely abuse. Areas like the knee, those are exposed areas. Children always get bruises over there. And then shape as well. If the shape looks like a cigarette butt, then it means it is a cigarette butt. If the shape looks like a hanger, it means that it is a so what's the shape? And then whether it's suspicious or not, in the sense that can you explain these bruises? Can you sometimes if the history are different, father tells a different history, mother tells a different history, so probably there's a very suspicious history behind that. So yeah, that's it.
Thank you, Doctor. Thank you, presenter.
Okay, I think if no other question, I think that should be enough. I'm a bit busy. So this afternoon, is it with your group or the other batch? Is it the other group? Not with your group. Fine. Okay, let's end our session with tasbih kafarah surah.